symptoms there. Now, this kind of epidemic of claims of sexual abuse buried in consciousness sprang up under DSM-3 and became a true epidemic. Millions of families were traduced by this idea, and the epidemic collapsed not because organized psychiatry in its journals began to recognize the falsehood of many of these recovered memories, recovered with hypnosis and other suggestive things, but because the courts and the malpractice claims became so huge that all insurance companies would no longer permit it. That put an end to this epidemic, not from our classificatory system. Dr. Treisman and I became interested in the expansion of PTSD over time, and here is our report from our depiction of the increased number of publications about PTSD from essentially the time of DSM-3 to 2005. It's an exponential curve, as you can see. That doesn't give you an evidence of what was really wrong. Look just what was happening in real studies. The National Vietnam Veterans Study in 1988, using DSM-3's diagnostic method for PTSD, said that 479,000 of the 3 million Vietnam veterans still had PTSD, now 15 years after all servicemen had left Vietnam. And it also claimed that 1 million veterans had full-blown PTSD at some time. But interestingly, only 300,000 had ever been in combat, and made you wonder about the nature of these diagnoses. The VA hospitals also gradually, encumbered as they became with patients with the diagnosis, demonstrated that many of the patients had, in fact, when they looked at their service record, had no traumatic experiences. And believe it or not, in the VA system, they discovered that some of the patients had never even been into the armed forces. If you're interested in this subject, by the way, you could turn to Burkett and Whitney's book entitled Stolen Valor, which was published in 1998 and demonstrated how many of these patients claiming to be PTSD veterans turned out to have been either suffering from other conditions or were themselves never in the combat services that they claimed. But look, the approach, the field guide approach, is fundamentally crashing for other reasons as well. One of the best and recent books by Hurwitz and Wakefield is this splendid book on the loss of sadness, which demonstrates that using the diagnosis of major depression from DSM-3, what's happened is they've encompassed under the same rubric patients who are bereaved, patients who have classical melancholia, and patients who have other sources of depressive demoralization. And they're all put in together. And that probably explains, by the way, the phenomenon that was demonstrated on Newsweek that antidepressants that used to work now don't seem to work for people with major depression. Sometimes they do work, and we're really back at the idea, well, what are these medicines good for, and who are they good for, because the diagnosis doesn't seem to identify them very well. Finally, the realization of this sort was expressed marvelously by our friend Stephen Schaffstein when he was president of the APA back in the 1990s, when he in his presidential address to the APA said, "We've allowed the biopsychosocial model to become the bio model," and got a standing ovation for his statement. An important and useful statement that other people certainly can confirm. And here is a little cartoon of what, to many extent, for many of us, it seems, psychiatric programs and psychiatric treatments are supposed to be, that we're just keeping patients moving through the system rather than understanding them, giving them labels, giving them pills, but not understanding them. This is going to be my fundamental theme in this lecture, the theme that I will defend. And if there's anything that you could carry away from this is this one. The discipline's fundamental and continuing problem with these issues that I've described lies with its commitment to a field guide as a method for classifying mental disorders. Classifications, let me remind you, going back to what Morton Kramer is saying really when he talks about a systematic system in ICD, classifications should be heuristic systems. They should serve to encourage and direct and stimulate discovery and investigation. And that means stimulate and direct for physicians rational treatments and research. Field guides, by their nature, lack heuristic features. They tell you how to name something like the sparrow, but they don't tell you anything about its nature, its place in our country, or its generative sources. And that's what applies to these psychiatric disorders or any medical disorder, any medical system that will work with a field guide. It gives no direction to the treatment or research of these conditions that it names. Fundamentally, naming is not enough, even when we agree about the names. Now, what is DSM-5 proposing? Well, fundamentally, it's proposing that we'll all just do the same with an upgraded field guide. That means that they tell us, at least in what they're proposing, is that they're going to add a few more categories. They're going to change some of the criteria in the old categories, and they're going to add some dimensional features that fundamentally are dimensions of severity. They are going to present us with another upgraded field guide, and whether being upgraded here is useful or not is anyone's guess. It's as though they think that maybe something will change for the better if we just keep doing what we've been doing for 30 years. And that's my problem with it. I think that we have to at least encourage the editors of DSM-5 to begin to put into place something that looks like a guide to generation when we're thinking generation and cause when we're thinking of our classifications. We have been thinking about this matter for a long time here at Hopkins, and are making the point that psychiatry must move beyond a field guide, and DSM-5 doesn't plan to do so. Just how to move gradually and slowly is not a very difficult thing to propose, really, and that's what our proposal amounts to. Dr. Treisman mentioned that our book, The Perspectives of Psychiatry, is an attempt to present to its readers a logical approach to understanding psychiatric disorders that rests upon what we've known and what are implicit, really, in the knowledge base of most psychiatrists. And it says that we can appreciate disorders in psychiatry falling into four different families. But we also want to make a point that we use this metaphor perspective to say with a particular case, you can look into the case from different angles and see elements that may well have provoked the presentation. But the crucial thing to understand is that these particular perspectives have certain presumptions about their nature that illuminates the generation of the disorder in front of you. As I said, there are four perspectives that we use. We speak about the perspectives of disease, which works by the logic of categories and thinks about what the patient might have as a disease. We have the perspective, we talk about the perspective of dimensions, and we're using universal dimensions here of intelligence and temperament, and it works by the logic of gradation and talks about the problem that the patient has probably is due in some way to who he or she is. We distinguish the perspective of behaviors, where